Kick off the first day of this, the first session of today, and it is the session honoring the recipient of the Outstanding Achievement and Service Award. So please join me in congratulating Dr. Saxon. Well-deserving winner of the award. Dr. Saxon will join Dr. Mariani for a brief conversation after giving a presentation. So congratulations, Dr. Saxon.
You can have a seat for a second. I'm going to say some nice things about you first. Okay, good morning. I'm very excited to introduce Dr. Andrew Saxon to you all today. Dr. Saxon began his career in internal medicine and worked for 4 years as an emergency room physician before specializing in psychiatry. He has over 4 decades of experience as a clinical and research addiction psychiatrist at the University of Washington. Board certified with added qualifications in addiction psychiatry. He serves on editorial boards for drug and alcohol dependence and general hospital psychiatry. His research, supported by the VA and NIDA, focuses on treatments for alcohol, tobacco, and opioid use disorders, as well as co-occurring PTSD. He is a distinguished fellow of the American Psychiatric Association and a fellow of the American Society of Addiction Medicine. Dr. Saxon, if you'd like to join me here to accept our Outstanding Achievement and Service Award, in recognition of your exceptional contributions to the field of psychiatry, your dedication to advancing the treatment of addictive disorders, your commitment to education and mentorship in mental health. Your impactful research and service have greatly enhanced the lives of many individuals struggling with addiction and co-occurring disorders. Please, let's congratulate Dr. Saxon.
Good morning, everyone. As you can all imagine, this moment's one of the high points of my professional life. Like many of you, I belong to many organizations, but AAAP is really my affinity group. Being in a room with a bunch of psychiatrists is where I feel comfortable. So I can't tell you how overjoyed I am. I'm also very appreciative that this award's fairly small because I am at the stage of life where I'm trying to downsize, and so, a big thing would have been a problem. So I want to spend a few minutes talking to you about the CHAMP study. That's collaborating to heal mental health and addiction in primary care. It's a randomized trial that my colleagues and I at the University of Washington recently completed. Let's see here. Oh, so I guess I have to. Oh, I see where I can look at the screen right there. So those are my disclosures. Here are the objectives, and the main thing I want to impart is what is the collaborative care model that was developed at the University of Washington. And before I go on, let me ask. Are any of you working as consulting psychiatrists in a collaborative care model at this point? Oh, okay, well, there's a handful there. That's great. And I hope I inspire the rest of you to think about making that a part of your practice, because I'm going to try and convince you that that's a way we can really expand our reach and have our expertise help a lot more patients than we can sitting down individually with one patient at a time. So I think these are the basic premises behind the study I'm going to tell you about. I think that the first 3 bullets are kind of what we all live with every day, so I don't think that's at all controversial. Whether primary care is a good access point to get more people into treatment, I think that still remains a little uncertain, and I think our study maybe contributes to some knowledge about that. But we know we're not getting our treatments out to the number of patients who need it, so we have to find ways to do that. So this was a cluster randomized trial to examine the collaborative care model for treating a co-occurring opioid use disorder and psychiatric disorders in the primary care setting. And the 2 aims I want to talk about First of all, does screening for OUD in primary care Is that a good way to find patients and get them treated? And then is the collaborative care model that's designed to treat OUD and mental health conditions superior to the standard collaborative care model, which is just designed to treat mental health conditions? The study was funded by the HEAL initiative, which you're probably all familiar with, a big push by NIH to deal with the opioid epidemic and the treatment of chronic pain. And our study was actually funded by the National Institute of Mental Health, and there were 4 sister studies that were all funded by NIMH. And I think ours is the first to report out, but it'll be interesting to see what the other studies found. The design was a little bit different in each one. So let me talk to you first about the collaborative care model that was developed at the University of Washington by one of my colleagues, Wayne Caton, who unfortunately passed away way too young. But he had this conception a long time ago that the patients we need to treat are in primary care, and how can we do this best? So focus on that triangle in the middle of the slide. At the top, you have the primary care provider. That's the person who's going to be making the diagnoses and doing most of the treatment. In the lower left corner of the triangle, you have a care manager. So that person might be a counselor or a social worker who's going to manage the mental health care of the patient and probably provide some basic forms of psychotherapy. And then you have at the right-hand corner, the lower corner of the triangle, you have the consulting psychiatrist. So the consulting psychiatrist communicates mainly with the care manager, and they use a patient registry to every week go through the case list, and the consulting psychiatrist advises the care manager on how to perhaps change treatment for the patient if necessary and optimize the treatment. And the patient, of course, is in the center. The patient communicates with the care manager and the primary care provider and rarely would ever see the consulting psychiatrist. But as you can imagine, 10, 20, or 30 patients can be discussed in an hour or two, and they can all get their treatment improved by having that psychiatric expertise. For some reason, I had my slides a little out of order, so I'm going to just skip ahead. So this slide presents the differences between our control condition, which is collaborative care for mental health conditions only, and in the rightward column, it's the additions for the CHAMP study that focuses on OUD. And I should say, if people don't know this, the University of Washington collaborative care model has been tested for treating depression and anxiety, has been tested in many, many clinical trials, and meta-analyses have been done, and it's clearly more effective for treating the psychiatric conditions than routine care in primary care. And actually, one of my colleagues on this study, John Fortney, just came out with a new study that was, I think, published last month, where they successfully treated PTSD in primary care using this model. So on the left column are some of the core principles of the collaborative care model. And so, I should have memorized this because I can barely see what's there, but I'll do my best. The population-based care, so you're using a registry, as I mentioned. Oh, that helps a little bit, but my eyesight, that helps a lot, but my eyesight isn't what it once was. And so for the study, we designed a specific registry that added a lot of things to be included concerning the OUD treatment, which was mainly with buprenorphine. And the second row is a really important aspect of the collaborative care model: measurement-based care and treatment to target. So what that means is you're going to measure how the patient's doing with standardized instruments. So for the the regular collaborative care model, that's the PHQ-9, the GAD-7, and the PCL-5. And if the patient is not, if the scores on those measures are not coming down, treatment to target means you must do some kind of intervention to try and change the treatment. And we added a lot of measures on for OUD, including one very simple one that we theoretically invented, but it's what we all do with our patients that we're treating for OUD, which is 4 simple questions. Are you having withdrawal symptoms? Are you having cravings? Are you using non-prescribed opioids, and do you have side effects? And based on the responses to those questions, which we're all very familiar with, you'll make a determination about changing the care. And I should also say that the control condition was not precluded from treating OUD. They just didn't get all the help that you see listed in that rightward column. And in fact, one of our control clinics happened to be, just based on the randomization, happened to be a clinic where there was an addiction medicine specialist working there who probably enrolled more patients than any other site, or very, very close to it. Those patients could get treatment, but they didn't get the assistance that we provided. Let's see, I've got to go back. Okay, so this is a multi-site cluster randomized trial. So the cluster randomization means that it was the clinics that were randomized, not the patients. And the reason for that is pretty obvious. If you train a care manager to deliver a beefed up intervention, and then you tell that care manager, well, for patient A, you use that intervention. For patient B, you go back to the standard thing. That's never going to happen. So that's why we're randomizing clinics we randomized them within healthcare systems, hoping that they'd be pretty similar. And you can see from the map, we had a pretty good spread across the country. And they needed to have it's a hybrid type 2 trial. So that means we have both an implementation and an effectiveness aim, and we're just going to talk about the effectiveness this morning. So they needed to have both, whether control or intervention clinic, they needed to have primary care providers willing to prescribe MOUD. They had to have a care manager on site, and they had to have the psychiatric consultant. 42 clinics randomized, only 24 actually enrolled patients. And I should mention that the RFA for getting the grant came out in like early 2018, so we were rushing around in 2018 trying to put our application together, and we got the funding in the fall of 2019. And we had time to plan the study, get ready to go, and we ran into the double buzzsaw of the COVID pandemic and the fentanyl epidemic. So 2018, I mean, for most of us, especially on the West Coast, fentanyl was just a glimmer out there. And then suddenly, by the time we were studying the study, it's everywhere. And we went from thinking all this would take place in person for these clinics to have to do it virtually. So it was a really challenging period of time. So some of the clinics that got randomized actually had to drop out. The clinic, as you saw, they're in all regions of the country, all different types of payers and healthcare systems. So I think this helps our generalizability a little bit. So let's turn to some of the findings. Our first aim was to determine if screening for OUD in primary care is an effective way to find new patients. So the way we did this, we used electronic medical records from the clinics, and we collected records for the 6 months prior to the implementation of the screening and for the 6 months after. And the screening measure we initially used was the NIDA modified assist, just the opioid section of that. And the reason I chose that was because back in 2018, that had the best sensitivity and specificity of any measure I could find to screen. It turned out, and it had been studied in a research context, and I don't think ever really applied in the real world. And it turned out it was pretty confusing to the patients and pretty confusing to the staff, and we ended up designing our own measure called the SOS, the Short Opioid Screen, which was just 2 questions. I don't even know if that was much better, but the clinics felt more comfortable. Some of them felt more comfortable using that. So what did we find? If you look at the histogram there, the y-axis is number of clinics, and the x-axis is more or fewer patients, new patients who didn't have a prior OUD diagnosis, determined in the period of time after the screening compared to before the screening. So if you look at 0, you can see there were a few clinics who actually found fewer patients with OUD, and then a few who found more. But basically, the median number of new patients found during screening was 1.5, and the range should be -4 to 17, not 4 to 17, obviously, because of where the median is. So we had to conclude, which is not what we expected, that screening for OUD in primary care is not effective. Now, bear in mind, this was in the context of the COVID pandemic, so it might have been different if we were bringing all the patients in person. We think stigma was a part of it. We think that in the real world, especially for patients being prescribed opioids, they may not be willing to acknowledge some of their symptoms of OUD for fear that their opioids would be stopped. But also, I think a big issue is that in most primary care settings, about 1% of patients have OUD. If you're screening 100 people to find 1 patient, that isn't very efficient, and it really is difficult for staff morale to keep doing that. Whereas if we're screening for depression, we're going to turn up 10 or 15% of the people we screen, or if we're screening for alcohol use disorder, same. So there's got to be a better way to identify patients than doing this universal screening. So I'll tell you about the patients who we enrolled, early middle age. They were mostly white. Unfortunately, we had a health system that treated primarily black patients and a health system that treated primarily Hispanic patients, and both of those, unfortunately, dropped out of the study after, one enrolled 1 patient, but it was just too difficult in the context of the pandemic. There were more women than men, which typically for OUD, more men have it than women, but there are more women enrolled in primary care, so there's going to be more of them. Here's their opioid-related information. So the first point is actually like 2/3 of the way down the slide. These were how many people were already on medication for OUD when they enrolled in the study. And because the screening was ineffective, we had a hard time finding new patients. So most of the patients, about 80%, were already on medication when they started. And also, this information about opioid use was obtained by survey, asking about how many days of opioid use in the last 30 days. And you can see it's a fairly low number because most of these people were already being treated. Still, there was a fair amount of craving that was reported. And you can also see at the bottom that a lot of these people had non-lethal overdoses. So they still had serious problems with their OUD, even though their use was so low. And when we saw how low the baseline use was, we go, my God, we're going to really have a floor effect. We can't drive it any lower. But lo and behold, here's the yellow is the intervention clinic, the green is the usual care or the collaborative care just for mental disorders. And you can see that at 3 months and 6 months, although the opioid use was very low, there was a statistically significant difference between the conditions with the intervention clinic having fewer days of use. Just because it's statistically significant, you could ask, is this clinically meaningful? And I'm biased, but I would argue that if every episode of opioid use incurs a risk for overdose, so even if you can reduce it by 2 or 3 days a month, I think that's a valuable outcome. And just to look at it another way, we looked at the patients who reported no use at baseline and how many experienced what we used to call relapse and we now call return to use at 6 months. And that's to me, that's a not only statistically significant difference, but a pretty clinically meaningful difference. Finally, what happened with their mental health conditions? So we used the VR12, which is a version of the SF12, which is a shortened version of the SF36 that used to be the most common measure of health-related quality of life. And just for those maybe not familiar, the way this is set up is there's 12 questions, about 6 of them relate to mental health. You get an overall score for mental health, and that score is normed to the general population. So a score of 50 is average for the general population. So if you're above 50, you have better mental health than average. Below 50, you have worse mental health than average. Every 10 points is a standard deviation, and 5 points of change is considered a clinically meaningful change. So what you can see is these people started off about a standard deviation and a half below average. So they really had serious mental health issues, but we didn't, and everyone improved over time. They didn't quite get to 5 points of improvement, but close. But there wasn't any difference between the conditions. And again, the control condition, which was pretty robust, was specifically treating mental disorders. We kind of hoped that if we successfully treated OUD as well, their mental health would get even much better, but that's not what we found. So that kind of completes most of what I wanted to tell you today. We did have a steering committee and made up of ourselves, people from NIH, other experts from around the country, and people with lived experience. And I will point out that Catherine Cates-Wessel graciously agreed to be on our steering committee, and Catherine gave us a lot of very helpful pointers as we were struggling to complete this study, and so AAAP had a seat at the table. And this pretty much unreadable slide conveys everyone that I need to thank who participated in the study, and you may not see the names, but you can see the complexity of trying to do this cluster randomized trial and do implementation and see what it took. So then references, and I guess I'm going to sit over here.
Okay, thanks, Dr. Saxon, for reviewing some of your recent important work. So I had an opportunity to review your 63-page CV, and we talked a little bit the other day just in preparation for this. So I'm just going to ask you some questions. Just, when we do this award, I think it's a nice way to just reflect on how someone's career and professional development evolve over time. And, so most of my questions are going to be on those types of issues. So you had told me when we spoke you were drawn to medical school and that psychiatry was, quote, an inferior path culturally at that time within the House of Medicine, which is not the case anymore. It's so interesting, that psychiatry.
Yeah, we're getting more people coming into psychiatry every year, which is great.
Yeah, I mean, when I applied, it was if you wanted to do it, you could do it, but people don't match now. So you went into internal medicine, and why don't you tell us about those decisions, and then worked in an emergency department. How did you make those choices?
Yeah. When I was in medical school, definitely my psychiatry rotation was by far my favorite rotation. I loved working with the patients. Back in 1975, our tools to deal with serious mental illness were pretty minimal and primitive compared to what we have now. But at my medical school, internal medicine was the highest thing you could do. And it was a really tough decision. And actually, at that time, believe it or not, you could apply to psychiatry, and it was only a 3-year program. You didn't even have to do an internship. And am I glad in retrospect that I didn't do that, because as grueling as I did an internal medicine internship at LA County USC, which is just down the coast from here, and it was all poor patients. And I learned an incredible amount about medicine in general and gained a lot of confidence. But we took care of a lot of patients with substance use disorders. In those days, we called them addicts. And we were very angry about taking care of these people because as we conceptualized it in the 70s, these are just people who were harming themselves. And they're making bad choices. And so that's kind of the environment there. But then I knew that internal medicine was not going to be for me, even though I learned a lot that year. And I happened to get a job offer, which would be just about impossible now, but there was a hospital in a rural area of Washington State that Grays Harbor that was desperate to have emergency department physicians. If you had a MD and a license, they'd take you. And of course, I knew very little about being an emergency medicine physician. Back at that time, there were no residency training programs for that specialty. But I went there. Again, it was a great experience doing that for 4 years. I learned a lot. And what I figured out was these nurses really know what they're doing. So you just let the nurses tell you what to do, and if you do that, everything's going to be fine. Then after 4 years of doing that, I go, well, what I really want, I'm just going to go back to what I really wanted to do, which was psychiatry, and then I entered the residency at the University of Washington. And I've stayed at the University of Washington ever since, which is an institution that I absolutely love, and I'm so fortunate to have been able to work there through most of my career.
That's great. So you told me when we were speaking the other day that you, quote, stumbled into opportunities. Tell me a little bit more what you mean by that.
Yeah. So I was doing my residency at the University of Washington. I was working a lot at the VA. I became chief resident at the VA that year, and I liked working with veterans. And my vision at that time was, well, I'd go into a private psychiatric practice, but I just didn't feel ready to do that. So I said, well, I'll just take a job at the VA for a couple of years. And what I was expecting is, they're going to offer me maybe a job on inpatient psychiatry, and I'm going to be taking care of patients with schizophrenia and major depression. That's, kind of the epitome of what psychiatry does. And then they offered me a job in the substance use disorders clinic, which at that time wasn't even on the VA campus because they didn't want those patients mingling with the other veterans. And I go, I just feel slighted. I feel disrespected. Why aren't they giving me the better job? But I'm only going to be there for a couple of years, so I'll take this job. And the bulk of the clinic was treating OUD with methadone, so it was an opioid treatment program. And I probably was there for 4 or 6 weeks. I quickly learned how to do methadone treatment, and I go, my God, I've been treating, and keep in mind in the mid-'80s, we only had first-generation antipsychotics, and the only two classes of antidepressants we had were tricyclics and MAOIs. So the treatments were not what we have now, but oh my God, I've been treating these people with psychosis and depression, and most of the time they don't even get better. And I put these patients on methadone, and it transforms their lives just in a very short period of time. This is much more gratifying. I'm so glad that I didn't go to inpatient psychiatry. And I also found, in contrast to my time at LA County USC, where I was taking care of the medical problems of the patients who were using substances, I found when I treated patients with methadone and also with respect, and they got a little psychotherapy, these are great people. I really enjoy these people. Their life stories are really interesting. And I'm learning a lot just getting to know them. And after a couple months, I go, wow, this is, addiction psychiatry is really my field. And of course, like all of you, I'm thrilled that I stuck with that.
So that's really great. Like, I think it's important I'm looking at the audience. The junior people sleep in, I think, and miss this talk, which is...
That's because they can.
Which is
the rest of us wake up too early.
which I think is too bad because, like the median age of this meeting is, right, this session is higher than the conference, I think. So it's too bad because there's a lot of wisdom coming out right now, but I don't know, that's how life is. But I think it's important to, when talking to people earlier in their careers, to emphasize like the random nature of career development, because whenever you anybody describes their career, it's like linear, but the reality is it's like totally chaotic as it's unfolding. And I mentioned your 63-page CV, and you've had this huge research career, but you haven't said anything about research yet. So how did you find your way into research?
Well, as we all know, medical school and residency doesn't give anyone much training in research. So I didn't really have a plan to be in academics or anything, but I met a psychologist who was working with me in that addiction program that was off campus, and he had a lot of research skills, and he was looking for a partner. So Don Carlson, a very close colleague and friend who also unfortunately passed away too young, but he and I just developed a great partnership, and he did a lot of the data analysis, and I helped by doing the interpretation and writing papers, and we applied for some grants. We got some grants. The initial one was looking at HIV prevention interventions, and then we got another grant that was looking at contingency management in methadone treatment, and it snowballed from there. And I found, I can really do this, and I could learn and teach myself the skills on my own. And of course, there were many disappointments because most of the grants we apply for we don't get, and you can get deterred by that. But I was also lucky being at the VA. I had a steady salary, so I didn't have to worry about supporting myself, and I just kept trying and eventually got some funding and developed more collaborators, and it expanded from there. And it's been, it's hard for me to imagine how much I would have enjoyed the work if I were just a clinician grinding away every day. For me, the learning and the seeking new knowledge that you get from research is pretty rewarding.
So what specifically do you find rewarding about grant process, running trials, writing them up? Like what is the intellectual?
Well, a lot of it's when you get knocked down, being willing to get up on your feet again and keep trying. But it's just it's almost like a mystery novel or something. We're going to try these things. We're going to see what happens. We don't know what's going to happen. Half the time, our hypotheses are disproven. But it's just very intellectually stimulating and exciting. I mean, it seems like it could be boring, just poring over data, but to me, it's pretty fascinating. So
tell me a little bit about getting addiction psychiatry recognized and your role in like establishing fellowships, because you were like one of the earlier programs to be created.
Yes. So probably you all know that addiction psychiatry first became a recognized subspecialty, I think, in 1992. And at that time, if you could document that you'd been in clinical practice doing addiction psychiatry, you could take the exam and be grandfathered in. But then there was a plan to, as for any subspecialty, people complete fellowships, and there was a plan to establish the fellowships. So I happened to be in a position at the VA where we had some funding to do that. I know it was a paperwork-heavy process, which fortunately I have no memory of the details, but I did all the application. We had a site visit to approve it, and yes, we got our fellowship approved in 1995, which was the first year that fellowships could be started. I think there were probably maybe 3 or 4 other programs at that time. I'm not exactly sure. And then, of course, I think there's like, what is it? Do we have like close to 100 programs now? Or I'm not really sure anymore. I haven't been tracking that. And that has been one of the most gratifying things that I've done, training other psychiatrists to do addiction psychiatry. And I think actually we have so many graduates of the fellowship who are here right now, and of course there's even more. We've completely permeated the Department of Psychiatry at the University of Washington. I think we might be about to take control of it completely, but right now I'm learning so much more from the fellows who completed our program than I'm able to teach them, because things are changing rapidly. They've got less calcified minds, and they're open to new things, and they're teaching me about that. So that's really wonderful.
Yeah, I was just randomly talking to someone after a session yesterday, and they were one of your former fellows.
Yeah, many of them are seated in the back row there.
There we go. You know, it's interesting because I think like last night I was at the NYU group organizes a dinner, and Mark Gallanter's like I think that these, like, especially the fellowships that were from the original, like you have this whole family tree of, you know, dozens of people who have been trained over the years. And when we come together at this meeting, it's interesting. It's kind of like a little bit of a family reunion. So what are some roles that you have now? Like what else are you doing, just in terms of your career at the moment?
Yeah. Trying to figure out retirement. So I did retire from the VA in July of 2024 after 40 years, and I have to say it wasn't planned that way, but my timing was really good because some things have happened in this country since then that have I would say made working for the federal government a bit challenging. But what else am I doing? I'm still working with the NIDA Clinical Trials Network on, again, trying to get more funding. A lot of it's doing that, and Larissa and I are working on a study comparing Brixadi to sublingual buprenorphine in a randomized trial in rural areas, and that's been really interesting and really exciting. I developed a collaboration with Deborah Hassan at Columbia, who is for those who don't know her work, she's a preeminent psychiatric epidemiologist, and she was very interested in the impacts of cannabis legalization, and we determined that the VA electronic record would be a very good resource for studying that, because the VAs around the whole country, so you've got VAs in states that have not legalized and VAs in states that have, and from the electronic record you can determine the rates of cannabis use disorder diagnoses, and so we've spent several years trying to look at the implications of legalization, and I can say there's a very small effect of legalization in terms of increasing rates of cannabis use disorder, but the main thing that we're really seeing is in all states across the country, in the VA, the rates of cannabis use disorder are going up. It's hard to know how much of that is actually more incidence, or are we just more sensitive to the diagnosis? But that's another project I've been working on for the last several years. And then as a sideline to my work at the VA, I kind of got pulled into a little bit of a forensic practice because I had attorneys contacting me wanting to use my expertise to testify in mostly civil lawsuits, but some criminal cases as well. A lot of that focused on substance use disorders, but more recently it's more focused on PTSD diagnoses. And so that I'm kind of keeping in with, at least my assessments ability, I'm keeping up because I'm doing a lot of evaluations for these people involved in legal actions. And I find that very gratifying as well, especially for people who've been involved in a traumatic situation, usually with a fair number of physical injuries, and the physical injuries heal and they're just not getting better and not getting back to where they were. And sitting down with someone for a couple hours, taking a very thorough history and going over with them what is entailed in PTSD, the light comes on and they realize, oh, I have a psychiatric disorder that can be treated and that's why I'm not doing well. So I find that to be a good contribution that I can make. And it pays well too.
So tell us a little bit just about what your involvement in AAAP has been over the years. I mean, I know when we spoke, you've been a long-term member and done some work for PCSS, and but what's your connection to this organization?
Well, I think the connection is all the relationships, and that I have worked with and know so many of you, and again, we have a bond that very few of us have with our other physician colleagues, and so that's been really good. But yeah, in terms of formally working with AAAP, my work has mostly been through the PCSS, which has been run by AAAP for probably 15 or 18 years now, and so I've been a lead mentor all along, and helping to get the training out across the country to people who are willing to learn about treating opioid use disorder. And now that obviously PCSS is going into alcohol use disorder as well, which is great.
What advice would you give, since you have this long history of being involved with PCSS and the mentorship program, what advice would you give to both junior-ish people seeking mentors and for more advanced people, professionals in their roles as mentors? What wisdom would you offer about just the process of mentorship?
That's a really great question. So I haven't thought about that very much, John. I've just been trying to do it. So,
So right here live, you're going to distill it.
Yeah, I'm going to try. I think the key thing for me is being very supportive of people that you're wanting to mentor, and figure out what their pace of learning needs to be, and follow their pace of learning, and actually using Skinnerian principles by reinforcing their work when they're going in the direction that you think is best. And in terms of mentees, I like having people that I'm mentoring who challenge me. It doesn't happen often enough, but that's very helpful in that mentor-mentee relationship, to have some back and forth and maybe have some disagreement and try and resolve that. Because we all know there's not one single way to do things.
So as a influential figure in academic addiction psychiatry, how do you see the future of addiction psychiatry, and where things you think need to go in terms of policies for the treatment of SUDs in the future?
Well, I guess the first thing I would say is I'm glad I'm not going to be the one who's going to figure that out. But I don't know. To me, conditions are changing so rapidly, and they're very different than when I started. And I think it's harder and harder to get funding for research. And of course, right now, we don't even know what kind of budgets are going to be available. It's unclear to me how artificial intelligence is going to affect the work that we do. It seems like it's already having an impact that I will confess I don't fully understand, but we're going to have to grapple with that. And then I think going back to my presentation, we have to figure out ways to get our expertise out to a lot more patients. And I mean, the model we have is one way, but there could be other ways. And again, I'm not going to be the one figuring that out, but I hope all of you here will contribute to that.
So, you know, the AAAP, we spend a lot of time appropriately, you know, trying to draw junior people in and creating opportunities for them to get involved in the organization and to facilitate connections to fellowship programs or to mentors or to other opportunities. But something I think we don't probably talk about enough, and when I did this with Ismani last year, I asked her the same question, which is, you know, as someone in a later stage of career, which advice would you offer for people who are further along in their careers? Because I think psychiatry is something where, I don't know, this is just my impression, I think like surgical careers just end abruptly, like you're going full speed and it stops. In psychiatry, you really do have the opportunity to kind of downshift a little bit, and I think probably not, like we never have a session on like, you know, later stage career planning, and I think these talks are an opportunity to do that. So I don't know, you're in the midst of that. Do you have advice for people about how to approach that?
Well, I would say, in my experience, having a lighter schedule is really wonderful. So, but I would say that it's been a struggle to have some of the things that I used to do that were meaningful to me, that I've relinquished them, and certainly, so it's been a year and a half since I retired from the VA, and I would say, I do have a without compensation appointment to the VA, so I still have access to the VA system, and I would say I was way too involved in reading VA emails and trying to stay connected that I didn't really need to do. So it's been a process of learning how to wind down. But I think you know, we all know how to do medication tapering, and so I think work tapering is a pretty good way to do it. I'm happy that I didn't just stop abruptly. And as long as I'm physically and mentally capable, I'm going to try and keep doing some work. Okay.
Well, listen, I really enjoy you giving us your time and your presentation on your academic work and discussing some more of this personal material. And so I think it's very obvious this award was well deserved. So everyone join me in congratulating Dr. Saxon once more.
Thank you all. It means a lot to me.
Another round of applause for Dr. Saxon. So right now we have a couple minutes. If you were trained by Dr. Saxon, if he was a mentor or if you work with him as a colleague, please come up to the stage right now. We're going to do a photo with him in the middle. Over there, over right here in front of the stage. So again, if you were trained by him, mentored, or you work with him, please join right here. Dr. Saxon actually interviewed me for residency back in 1997. I sat in his office, I said, why should I come to University of Washington? He said, Tim, it's Seattle. What else do you need to know? Interview is over. So, again, right over here.
Hello, everyone. Seth Acton here, project manager for PCSS MOUD, long-standing cooperative agreement which AAAP has led the way on for nearly 20 years. Let me give a quick plug for PCSS MOUD. We're doing great free educational training for so many, and if anyone here is looking to get involved, please reach out to me. Just grab me aside at some point this weekend. I would love to talk to you about it. We have lots of opportunities where your expertise could come in so handy to help train so many people. So just let me know, PCSS MOUD, we need your help. But I'm not here to talk about PCSS. I'm here to award a prize for the recent trainee scavenger hunt. So they had to track down a lot of people, talk to people, engage, post social media, a lot of stuff. And we have one person who won a grand prize. And this is that prize. And that prize is housed in a prize itself, which is this beautiful gift bag. This bag could be yours. That's right. This bag could be yours for only $6. I mean, in San Francisco terms, that's $0. Nothing costs $6. But you can get this for only $6. All you have to do is take a left when you leave these doors, go to the registration table, cold hard cash or credit cards. We accept both. This is an artisanal bag. You know, you rep AAAP with this bag, and it could be yours. One person, though, does not have to get this bag. One person wins not only this bag, but the wonderful goodies within, and that person is Alag Porvanchi. Are you here, Alag? Please come and collect your prize. Alag Porvanchi, anyone? All right, Alag, you just need to come to the registration table, and you will get this great prize. A couple other quick announcements before I jettison off. We do want you to know that we are having networking bingo starting today. So be sure to grab your network bingo card. You can get that over at the registration desk. The first 5 participants, the first 5 who return with a fully completed card between tonight and Saturday night will win a prize. Yeah, I don't know what that prize is, but it will be grand, no doubt. So go over to the registration table and get your network bingo card anytime. And a reminder that tomorrow night we will be having the closing reception. That's always a great time. It's 50s themed. So, you know, do your research and bring your best 50s outfit and come on. I've been told that DJ MOUD will once again be spinning your favorite 50s tracks. So be sure to come out and get your dancing shoes on, get some food, network, and wrap up this conference in a great fashion. And that is all I have. So thank you very much for your time.